Yeah, good afternoon. Thanks so much for SAGES inviting us. I'll talk about pediatric hernias with the subtitle, No Mesh Required. How do you advance? Danielle, how do you advance? Oh, okay. Nothing to disclose. I guess 7 seconds. Since there's nothing, I don't have to. Mouse. Okay. Mouse. Okay. So pediatric surgeons see a large number of hernias. Different hernias, really. There's a huge spectrum of patients we serve. The tiny patient, the preemie, to really adolescents who reach 170 kilos here and there. And most defects can be surgically repaired with a low recurrence rate safely without complications. We do use mesh for some special indications, biomesh as well as permanent mesh. And the focus is a little bit of inguinal hernia, but I do mention other hernias we see in our practice too. Those are essentially our routine no-mesh hernia repairs, which come around every day. The umbilical hernia starts in babies, looks kind of scary to patients, as you see, can be big, very rarely gets incarcerated, really very rarely. So you can safely wait, and many of them actually close by themselves, so it would be unnecessary surgery. And so we wait 3-4 years and then repair them in an outpatient procedure straightforward. Similar with epigastric hernias, which only become symptomatic mostly in the teenage and then adult ages. As well as the spectrum of incisional hernias, gastroschisis, omphalocele, and congenital diaphragmatic hernias, which often can be just repaired primarily. The gastroschisis is, as you know, an abdominal wall defect where the patient is born with bowel on the outside, and you see the defect in the middle picture, and the umbilical cord is left long on purpose because we're using it as a plug. It gets trimmed to close this defect on the outside. Put a dressing on for 5 days, and this heals really nicely. You don't compromise the domain of the abdomen because you're just plugging the hole. You don't make it tighter. And the umbilical hernia most often actually heals, up to 80% of the time in the first 5 years. This even works, it's the miracle of the umbilicus, really, in larger defects. So if you have a silo in place, you see the umbilical cord is preserved here. The silo is removed and you have a large defect, which you plug again with the umbilical cord you preserved now for several days. And over time, this shrinks down tremendously and most often closes within several years. Indications for mesh repair, and we do use all kinds of meshes. Diaphragmatic hernia is often an indication, not always. And for that, we usually use Gore-Tex meshes or a combination. And we have commonly infants, children, adolescents, trauma, and sepsis who have an open abdomen, loose domain, similar than the adult world, and who need to be closed at some point with a biomesh. And then we do have, at times, larger abdominal wall defects which require mesh. And then the adolescent groin hernia, I'll discuss that a little more in detail later. Inguinal hernias in children, and remember, a good portion of those, as we just heard, are actually being repaired by adult surgeons, definitely above the age of 2. And most of them are indirect hernias. They originate from the patent processus vaginalis. There's the communicating hydrocele. Essentially, we treat it as a small inguinal hernia, although you don't see a groin bulge, just fluid coming through. And so we repair those usually. And then less common, but we do see them, are direct hernias, pantaloon hernias, femoral ones, sliding hernias, and amyant. You can see the whole spectrum at some point. In younger patients, so preemies, newborns, infants, and young children, no mesh is ever required in those patients. In fact, it's contraindicated because they obviously grow and they have 80, 90, 100 years to live, and who knows what happens with that mesh. The teaching in the pediatric surgery world was high ligation is sufficient. However, you need to remove a part of the hernia sac. And that was probably not really based on data, because we learned in the laparoscopic area that the high ligation is sufficient enough and has essentially not an increased recurrence rate if you don't remove part of the hernia sac and leave it in place. So we don't resect those necessarily nowadays, especially with the minimally invasive procedures. Most hernias in the country in children are repaired open, and there's a variety of reasons. It's a really well-established operation, good outcomes. It heals almost without a scar in many cases. Some ambulatory surgery centers don't allow minimally invasive procedures, like the one I have in Pittsburgh, for example, so we do always open repairs there. And traditionally, many surgeons would actually explore both groins because you often can find a processus vaginalis, and I'm not sure if that's more commonly in private practice, but that was a common approach, which nowadays is not common anymore because we utilize the laparoscope through the hernia sac and the groin and look at the other side. Like you see the image down below here, where here is clearly an open internal ring, there's a hernia sac, and so we would actually repair this on the other side too after we made this diagnosis. You can actually bill for that diagnostic laparoscopy. There's obviously a conundrum of the processus vaginalis because we don't know really what closes and what doesn't. There's no good data on that. And how big does the defect has to be really that there maybe is a hernia? But there are some studies out there and they say essentially it's about 30, up to 30–40% of all comers. Is the laparoscopic repair better in smaller children or the open? And they're kind of similar regarding recurrence rate. It depends really on the surgeon and the technique. Wound infections, there's data which is in both directions. And if you do a laparoscopic repair coming from the belly button, you look obviously immediately at both internal rings and immediately can evaluate the other side and potentially repair it. So it's shorter to do a bilateral repair. The downside, often we use a permanent suture for that, which sometimes the knot can be felt under the skin by the parents, especially in small, thin patients. And the upside is, if you have an incarcerate inguinal hernia, there's edema down in the groin, and that actually helps you putting the suture around the internal ring and closing the defect. And there are multiple techniques. The principle really is putting a suture around the internal ring. Here the needle is then, but it's at the seal technique, passed back with its heel, and then it surrounds the internal ring and you close it. There's a lasso technique, which commonly is used where a little instrument helps passing a hollow needle, a suture lasso essentially, and then do the same thing from the other side, and one lasso pulls the other suture around the hernia sac and you tie it. And that's the high ligation. Adolescent inguinal hernias. In small children, we talked about prosthetic reinforcement is contraindicated for all those reasons long-term reasons of the mesh. But the adolescent patient is a gray zone, and it's obviously even more commonly treated by adult surgeons. And there's a heterogeneous spectrum of patients. When you look at the adolescent, there's the 30-kilo 12-year-old, but there's also the 150-kilo football player or obese patient. So there's a paucity of data on that. And Bruns looked recently, sent a survey out to adult and pediatric surgeons and looked at their opinions, and in a standard patient adolescent hernia, 65% of adults would use mesh, adult type repair, while most pediatric surgeons just do a high ligation. And for large defects, however, or very large defects, they would both use mesh. So the experience of patients in the country seems to be driven by surgeon preference and not really by outcomes or knowledge about this. And this study just came out about 2 years ago, and they looked retrospectively at a 16-year experience of 213 patients, of patients between 12 and 25 over 16 years, and they followed them up. 2/3 were repaired by adults and 1/3 by pediatric surgeons, and mesh was usually used by the adult surgeons. And they found essentially no difference in recurrence rate. When you look here, it's about 6% in both groups, as well as postoperative complications, as well as survey results. So the strongest association was a touch higher BMI of 26 instead of 23. And this paper from a Chinese group looks at 100 patients prospectively using biomesh instead of only high ligation. They found the high ligation group had 3 recurrences, usually the larger one. So maybe biomesh is a good solution for some. So what is the optimal management for adolescents? It should be driven by disease, but it's actually driven by surgeon practice nowadays. Young patients don't need mesh. There's no data, unfortunately, and high ligation seems to be good for the standard defects, especially if the patients are not obese or athletes, obviously for recurrence. And the biomesh role needs to be explored. So in summary, pediatric surgeons repair a lot of different hernias. The standard adolescent hernia and pediatric hernia usually can be repaired by high ligation, although it's apparently not happening, depending where the patient is going in the country. And then for obviously adolescents who are in more higher risk groups, obese, very large hernias, potentially athletes, obviously recurrence, mesh probably should be used, but biomesh may have a role in the future. Thank you.